The main purpose of respiratory assessment is to determine the adequacy of gaseous exchange, oxygen in and carbon dioxide out. In a lot of clinical areas, we assess the oxygen in parts reasonably well, but we do not assess the carbon dioxide out very well, except in high-dependency areas where capnography is used in conjunction with arterial blood gas, ABG. Where immediate access to this is not available, we need to be able to assess the patient's breathing in other ways. When assessing breathing, the first thing to check is for air movement. Is the patient breathing? Do this by look, listen and feel, which will be explained shortly. If the patient is not breathing, summon help immediately. Check to see if the patient has a pulse, and then start breathing for the patient using either a pocket mask or bag valve mask, along with chest compressions if they are indicated. If the patient is breathing, then you need to assess if it is adequate. If the respirations appear to be very shallow, then breathing may not be adequate. The normal rate of breathing is 12 to 20 breaths per minute. However, making an assessment on depth and rate of breathing alone is not adequate. We also need to assess how much oxygen is in the blood, and there are two ways to do this, using pulse oximetry and measuring arterial blood gases. Select each of the links to find out more. Pulse oximetry is the easiest and simplest method to measure oxygen levels, but it does have its problems and limitations. Apply the probe to a finger or toe on the patient and then read the results. There may be no reading if the patient has cold extremities, is peripherally shut down, or is wearing nail varnish. Try another digit if there is no reading, and then, if you suspect that the machine is not working, try the probe on your own finger. Sometimes an ear probe may be more reliable. However, if the patient has any coloured dye injected for a radiological examination, this could give a false reading, as can carbon monoxide poisoning and sickle cell disease. It may also be difficult to get a reading from a shaking or convulsing patient. The normal reading should be greater than 96%, but patients with chronic obstructive pulmonary disease or some other condition may show a reading between 88 and 92% when breathing air. If you have problems getting a measurement, try a capillary refill test by squeezing the patient's finger or sternum for 5 seconds and ensuring that colour returns within 2 seconds. Arterial blood gas is an accurate way of addressing how much oxygen and carbon dioxide is present in the blood. This gives a more accurate state of ventilation. A sample can be taken direct from the artery with a needle or from an arterial line. If the patient is on oxygen, this should not be removed while the sample is being taken. The sample is then analysed in the machine and the results should be available in a few minutes. The results of either the pulse oximeter or the blood gas analysis will determine how much oxygen the patient will receive. The primary function of the cardiorespiratory system is to deliver oxygen and nutrients to tissues and to remove carbon dioxide and other waste products. The exchange occurs at the air-blood interface where alveoli meet the pulmonary capillaries. If either or both of the primary functions are not working correctly, then respiratory failure can occur. Failure can either be acute or chronic, and acute failure can occur within a very short time or up to a few days after the initial problem. The functioning of the air-blood interface is also important because there can be enough oxygen in the alveoli, but if there is not enough blood to carry the oxygen to the tissues, then respiratory failure can occur. This is sometimes called the ventilation-perfusion mismatch or VQ mismatch. Press Continue to find out more. If acute respiratory failure is not recognized and treated early, it is likely to be fatal. Early warning score charts should indicate to you that there is a problem, but your own knowledge and instinct can also alert you to a problem. Treating acute respiratory failure needs a multidisciplinary, collaborative approach, and help must be called quickly. It is important to identify which type of respiratory failure has occurred, as this will dictate the intervention and treatment for the underlying cause.